Our next speaker is Dr. James Koness. Dr. Koness trained in general surgery at Brown University. He did his surgical oncology fellowship at Roger Williams Medical Center. He is specialized in head and neck, melanoma, breast. He is the BCS head and neck surgeon in Rhode Island and the most experienced one. He's going to talk to us about melanoma. Please welcome Dr. James Koness.
Thank you, Abdul. So I'd say the theme of my talk today is, in 2014, why do we do what we do, and what's the data behind it? So the objectives are to understand the evidence for surgical margins, and let me just see how this. Okay, it's hard to use this for advancing. Okay, understand the evidence for surgical margins when excising a melanoma. Appreciate the evidence-based justification and limits for lymphadenectomies. To review adjuvant therapy for stage 4, adjuvant therapy and systemic therapy for stage 4 melanoma. Emphasize the importance of individualizing assessment and treatment planning. A couple of statistics. There's approximately a little over 76,000 cases of melanoma in the United States per year, making it the 5th most common cancer. Somewhat sobering statistic is that approximately 2% of us will be diagnosed with melanoma at some point during our lifetimes. It is slightly more common in men, and as you know, it's decidedly more common in Caucasians. Interestingly, it's one of the most rapidly increasing cancers in the United States, with an average rise of 2.6% per year over the last decade. Approximately a little over 9,000 patients die of disease, but leaves a very good cure rate of 91%. And the cure rate is markedly affected by the stage at diagnosis, with a 98% cure rate when it is localized, 62% when it is spread to regional lymph nodes, and 16% at best when it has distant metastases. So this is a slide looking at the SEER data over the last decade or the last 35 years actually, between 75 and 2010, demonstrating that increase in the number of new cases. And what you see from this graph is that the death rate is basically constant. So that either tells you that we have better treatment for advanced disease, which I don't think is true, or most of these new cases are relatively early cancer. So we're doing a better job of screening and picking up these cancers and taking them out before they become a problem. 84% are diagnosed in a localized stage, with just 16% in a regional stage and just 4% in a distant stage. As I've already told you, the stage at presentation markedly affects the prognosis. The melanoma comes from a cell that is in the bottom of the epidermis. And how do we recognize it? You all know your ABCDs. Asymmetry within the lesion itself, the border being notched, uneven, blurred, the color variation within the lesion, shades of brown, tan, black, and then larger diameter, generally considered bigger than 6 millimeters, should be considered suspicious for any nevus. So my outline then is, first, what are the prognostic factors and disease biology? What is the management of the primary tumor? What is the management of the regional nodes? What is the management of distant metastases? And I know Dr. Carvajal spoke about that yesterday quite nicely. And if we have time, I'm going to try to basically reiterate what he said, because it's very important and it's very interesting. So what are the primary factors on presentation that help us with prognosis? And this is a summation of Morton's data, who's recently departed this earth, and it's a great loss. And what he's pointed out here is that single most important factor in prognosis, which I've already told you, is the lymph node status. Other important presenting factors in determining prognosis is the depth, the Breslow depth of the melanoma, the thickness, and whether or not it's ulcerated. And that's reflected in the current staging system, where on the 7th edition of the AJCC, we now divide the tumors into an A and a B, depending upon whether they have ulceration or any mitoses per millimeter squared. And that's true of each of the depths. Likewise, in the nodal status, we divide patients into an A and a B, depending upon whether they have micrometastases or macrometastases, and macrometastases is defined as being either palpable or if you have extra nodal extension on the final pathology. The distant disease is also divided into an A, B, and C, depending upon the behavior, A being spread to skin, soft tissue, or distant lymph nodes, B and C, markedly worse prognosis, whether they spread to lung or to visceral sites, or any metastases with elevated LDH. And so you end up with a very complex staging system based on the numerous A's and B's, which is something I basically always have to look up. It's very difficult to remember. Okay, management of the primary tumor. This is Hunter. He first described what was eventually turned out to be a melanoma in a case report in 1787, where he described a patient, a 35-year-old male who had developed a recurrent tumor in his neck, and he described it as a spongy black mass, which was likely a lymph node metastases from melanoma, and he described it as a cancerous fungus excrescens. It wasn't until 1968 that that past specimen, which was kept all those years, was finally confirmed to be a melanoma. The term melanoma comes from Lenneck, a Frenchman who in 1812 coined the term in a paper with melanoma being the Greek word for black. William Sampson Hanley in 1907 gave a Hunterian lecture in England where he described a single case, which was pathologically well worked out, where the melanoma had spread into the subcutaneous tissues for a distance of, for quite a distance away from the actual skin apparent lesion. And so he advocated then a 1-inch skin margin and a 2-inch excision of the deeper structure. So it was kind of a cone down and around the subcutaneous tissue and fascia. Of course, they were dealing with very advanced melanomas, but that paper drove surgical therapy for 50 years. And so that formed the basis for trials that were taking place in the late 1900s to try to define whether that was necessary. So what's the argument on local control? Balch in his intergroup trial has a nice graph where he shows that local control is definitely associated with prognosis, and if you have a recurrence locally, you don't do very well. However, even every author, including him, freely admits that almost all these patients also present with distant disease at the same time. So there's something about their biology that leads to both local and distant control, distant failure. So what are the guidelines for margins? These are the guidelines, which I'm going to show you again after I show you the data, but I just want to point out a couple of things. All of the data is based on clinical margins, so it's basically what the surgeon says he did. There's no data to try to validate whether they were accurate with their margins or any pathologic data to support to verify that the pathologic data is conformatory to clinical margins. So you have to remember that when you look at every single paper, it's clinical margins. The second thing is that the data is based on category 1 data. The recommendations are based on category 1 data, which is randomized clinical trials, and that is true. However, I think after I go through the data, you'll understand that there's not a lot of data. And then lastly, the guidelines freely admit that these margins can be modified or accommodated to individual anatomic and functional considerations, and that is oftentimes done. So here is the randomized data that has been done. There's 5 trials listed here. There's actually been 6 that have been done in the literature, 6 randomized trials. One of them is a French trial, which is essentially identical to the Swedish trial. So I'm going to go through each one of these. And they're basically in order of publication. So the oldest is the WHO trial, which was run out of Italy. And basically, one thing you're going to notice here is all of them show no difference no difference in survival. And all but one of them show no difference in local recurrence. So but they looked at different patient populations, and they had different margin widths, so they're not completely comparable. The Berenice trial actually looked at the thinnest group of Breslow thickness melanomas, with all patients being less than 2 millimeters thick and an average of 1.1. The French and the Swedish trial looked at basically intermediate thickness melanomas between 0.8 and 2 millimeters, and look at the margins they started out with, which was, again, based on that description by Handley. And even the Balch intergroup trial looked at 1 to 4 millimeter margins, and again, the comparison was 4 centimeters. That's quite a margin. These 2 trials are more similar because they both looked at slightly thicker melanomas, or T3 melanomas, and one had a 1 versus 3 centimeter and the other 2 versus 4 centimeter margin. So we'll go through each of them to tell you how we get to the, I'm going to back up. One second. So all of these trials were done on truncal and extremity melanomas. None of them were done on head and neck melanomas. And you can see, obviously, you're not going to get a 5 centimeter margin on the face. So, I mean, for obvious reasons, those lesions were not included in any of these trials. And again, there's no data on pathologic margins. These are clinical margins. So first, the WHO trial, which was 612 patients, and you can immediately see there was between a 1 and a 3 centimeter margin. There was no difference in overall or recurrence-free survival. So they also were able to subdivide their patients into the group that was less than a millimeter, and the group that you'll see some data later that I'll show you between 1 and 2 millimeters. But in the first publication back in '91 by Berenice, there was no local recurrence in either 1 or 3 centimeter margins. So the conclusion of this paper was that 1 centimeter margins were considered adequate for any tumor less than a millimeter in Breslow thickness. Moving on to the opposite end of the spectrum, where we have more clear data, which is the thicker melanomas, or the T3 melanomas. Publication from Thomas, where he looked at melanomas greater than 2 millimeters thick. They had an average of 3 millimeters, and 38% were ulcerated. Randomized to 1 versus 3 centimeters. Somewhat more aggressive, radical treatment for a relatively thicker melanoma. There was no difference in overall survival. There was a difference, however, in local regional recurrence, with the 1 centimeter margin patients doing not quite as well as the 3 centimeter margin patients. And so his conclusion was that margins of 1 centimeter are not acceptable for lesions greater than 2 millimeters in thickness. Didn't answer any questions about 2 versus 3 margins. But it's interesting to note that if you look at his data, that there was actually no real difference in local recurrence, but the difference was due to nodal recurrence, with the 1 centimeter margin patients having a higher incidence of nodal recurrence, significantly different. This study was done in an era before sentinel lymph node biopsy, so unclear whether if you had a sentinel lymph node biopsy and acted on that, whether that would have led to different results. Gilgren, in a European randomized trial published in 2011, looking at 2 versus 4 centimeter margins in the same group of patients, which is greater than 2 millimeters. And there was absolutely no difference between the 2 and the 4 centimeter margins in local recurrence or in survival. So that led to the recommendation that for thick melanomas, a 2-centimeter margin is clearly good enough, thicker melanomas. For intermediate thickness melanomas, and there I mean between 1 and 2 millimeters. So we have a number of trials. The first is the Swedish trial, which had a medium of 1.2 millimeters thick, randomized to 2 versus 5 centimeters, so again, very aggressive, wide margins. And they showed no difference in local, regional, or distant disease or overall survival. So 2 centimeters are considered adequate. So there went the really wide Handleyan 5-centimeter margins. Balch, and I don't see Dr. Wanabo today, but he's one of the authors on this landmark paper. Again, looking at intermediate thickness melanomas to 2 versus 4 centimeters, and there was no difference in local, regional, or disease-specific survival with 4 versus 2 centimeter margins. Let me just go back a second. Okay. And then the last bit of data we have on that group of patients, which is the only data that I'm aware of looking at thinner margins than 2 millimeters, is back again at the WHO trial, where again they had 612 patients, but 253 were between 1 and 2 millimeters in thickness. And they were able to, again, no difference in overall survival. There was a slight non-significant increase in local recurrence for 1 centimeter versus 3 centimeter. But the conclusion of the authors is interesting and has continued to lead to some interpretation of this data and why the guidelines are written the way they're written. So Casanelli, the author on the lead author on this paper, wrote that it seems reasonable to conclude that there is enough evidence to state that an excision of 1 centimeter margin is a safe procedure for primary melanoma not thicker than 2 millimeters. On the other hand, is even written this year by Michael Stone, who wrote the up-to-date summary, concluded that we use 2 centimeter margins of normal tissue if this is feasible without the need for a skin graft. A 1 centimeter margin may be adequate if anatomically constrained based upon the location of the lesion. So I get back to the guidelines, and again, this is category 1 data based on these 6 randomized trials, and the WHO established that a 1 centimeter margin was good enough and adequate for a 1 millimeter thick or less melanoma. And the Thomas and Gilgren articles were able to show the data that a 2 centimeter margin is adequate for a 2 to 4 millimeter thick or T3 melanoma. But again, a little conflicting data or interpretation of the data for the T2 lesions, the 1 to 2 millimeters, and so the guidelines are written that you can either do a 1 to 2 centimeter margin. Now, the 4 millimeter, I didn't show any data on the really thick melanomas, and the recommendation is a 2 centimeter margin. It's largely based on the fact that these melanomas have very high incidence of distant spread, and they're patients who are going to more likely deal with distant disease issues in the future rather than local recurrence. So the margin is a 2 centimeter margin as recommended. However, I will state that almost every single one of these randomized trials shows that as the melanoma gets thicker, the likelihood of local recurrence increases. And so even within the T2 lesions, a 1.1 millimeter melanoma thickness is different than a 1.9 millimeter thickness. So in my mind, that's how I think about the kind of margin I get in my interpretation of this 1 to 2 centimeter recommendation. So moving on to regional lymph nodes. So why do we dissect out regional lymph nodes? There's basically 3 reasons. One, which nobody will argue with, is prognosis. Every single trial and in the statistical data that I showed you earlier showed that, that lymph node involvement is a clear indication of poor prognosis. The two other reasons would be for changing treatment. Is there anything you could give adjuvantly to these patients that would change their prognosis? Okay, so up to the 80s and 90s, there were a number of people who were looking at elective lymph node dissection versus observation, and every one of these trials would show that there is definitely prognosis, but most of them basically showed no difference in overall survival. So the last reason to do a lymph node dissection would be to possibly prevent that lymph node basin disease from causing disease elsewhere. In other words, escape of tumor from the lymph node basin or metastases from the lymph node basin. And nobody's been able to ever show that. Now, Balch, in writing the final paper on this intergroup trial, was able to pick one group of patients, which were the T2 patients, 1 to 2 millimeters thick with no ulceration and young age, and did show a difference, statistically significant difference, in doing the lymph node dissection. So there was still a little bit of debate, but it was really a small subgroup of patients. So only about 20% of patients who have melanoma will have lymph node disease at presentation. So if only 20% of patients could possibly benefit, then the other 80% could never possibly benefit. Given the high rate of complications and costs associated with elective lymph node dissection, the morbidity is hardly justified on the basis of accurate staging. So why do we still do lymph node dissections? Well, two things happened in the 90s that re-stimulated this debate. One was the development of the sentinel lymph node biopsy by Morton. The other was the development of high-dose interferon by Kirkwood and others, showing or purporting to show that you could do something for these patients to possibly change their outlook. So Morton went on to take his sentinel lymph node technique and randomize patients to sentinel lymph node biopsy versus observation. But again, and this was again intermediate thickness melanomas, he was faced with the same conundrum that the previous trials are, that only 20% of these patients could possibly benefit, and so there wasn't any overall survival benefit. There was a disease-free survival benefit, which is not surprising because those 20% of patients would have eventually failed in their lymph node basin in the observation group. And he then pointed this out further in subgroup analysis, where he took the 2 positive sentinel lymph node biopsy patients, that's group 1, compared them to group 3, which is the patients who were in the observation then had a lymph node failure, and that's this comparison here, and it was significantly different. So that's led to the ongoing MSLT, or multi-center selective lymphadenectomy trial 2, which is randomizing the only group of patients who could possibly benefit, the positive sentinel lymph nodes, to completion lymph node dissection versus ultrasound observation, and delayed lymph node dissection if disease is detected. So how do you manage, without that data, how do you manage a positive sentinel lymph node? Well, clearly, again, this is prognosis. Clearly, patients who have non-sentinel lymph nodes that are involved do worse than patients who have no further non-sentinel lymph nodes involved. Can you pick out patients who may need a further dissection and those who don't? Well, you can look at certain factors, disease burden, location in the node, even clinical data of residual thickness, but none of it's perfect. Do patients less than 1 millimeter need lymph node dissection? The answer is basically no. There's never been a patient less than 0.75 millimeters thick who had lymph node, very, very rare, I shouldn't say never. And those patients, even between 0.75 and 1, they usually have ulceration, regression, and mitotic index. So you can develop nomograms to try to come up with patients who are less than 1 millimeter thick who may need a lymph node, a sentinel lymph node biopsy. I guess I was cut off. So in concluding, the stage 3 spectrum has a wide spectrum of behavior with wide variation in 5-year survival. There are primary features that drive this: thickness, ulceration, mitotic index. but the disease burden is the primary driver in the lymph nodes. The last thing I'm going to conclude with is the Kirkwood data, which he presented which he first presented in the mid-90s, where he was able to show that adjuvant interferon would particularly help the patients with stage 3 disease. There were problems with this. There was some comparison between the groups that had more favorable patients in the interferon group. That it was some statistical anomalies with only a one-sided p-value test reported. This treatment has a lot of toxicity, and then it was not borne out by further data. And then to conclude, the meta-analysis published in 2010 of 14 trials looking at interferon between 1990 and 2008, generating 17 comparisons, over 8,000 patients, randomizing 12 of the 14 randomized patients to observation versus interferon. And the conclusion of this meta-analysis was that 10 of the 17 comparisons did show statistically significance in disease-free survival, and 4 of the 14 did show a overall survival benefit. So, that's still kept interferon alive for these patients. There's now a present trial looking at ipilimumab versus interferon in both the United States and Europe. Do you ever take out distant metastases from the MSLT1 trial? They were able to show that there is a role for occasional surgery, and this is going to be an increasing role. I don't have time to go into what Dr. Carvajal talked about yesterday, but as we do have systemic therapy, which is going to get patients to live longer, some of these patients will come back to you as surgeons, and the question will be, can you do anything about their disease? Well, the answer is sometimes. So clearly patients who have that M1A subgroup will benefit more than patients who have lung or visceral metastases, and clearly if you have less metastases, you're going to benefit more than if you don't, if you have more metastases. So I think I'll stop there. Thank you.